Good evening, viewers. Today our topic of discussion is redefining diabetic nephropathy. It simply means there are two aspects. One is diabetic nephropathy and second is redefining. So in order to describe what we want or what we intend to say, first we will try to establish the diagnosis of diabetic nephropathy, and then we will try to emphasize on exactly what is meant by redefining diabetic nephropathy. There are many things which we try to define but we cannot define. As for example, if we try to define what is serenity, what is peace, we may be at a loss to find out our words. But look at this picture and you can have an impression about what is serenity, what is peace. Similarly, if we try to define what is caring, what is love, what is affection, we may be once again at a loss to find out our specific words. Look at this picture, and this exemplifies the definition of love or affection. So there are occasions when an example may be more explicit than a definition. So before trying to define diabetic nephropathy, let us go into some examples. Look at this first case, an example, so-called case 1, a 16-year-old female. This female was admitted with dehydration, shock, with very high random blood sugar, 462, urea 104, creat of 2.1. The question is it diabetic nephropathy? The answer is obviously no, because this lady was actually suffering from diabetic ketoacidosis, pre-renal azotemia, hypotension, dehydration, and that was causing renal dysfunction in the form of high urea and creatinine. This disproportionate rise of urea also speaks of a pre-renal azotemia. So this is not a case of diabetic nephropathy. Let us see next case, the case 2. Here is a 65-year-old male diabetic who presented to the emergency with acute retention of urine. Creat 3.8, urea 65, random sugar 68. Once again, is it a case of diabetic nephropathy? The answer is once again no. This is not a case of diabetic nephropathy. This is a patient who suffers from diabetes and obstructive nephropathy having renal dysfunction. So once again, this is not a case of diabetic nephropathy. What about this case, case 3? This young man was admitted recently under internal medicine. 32-year-old male, diabetic for 4 years, presented with fever, skin rash, he had oliguria, blood pressure was around 160/100, maybe because of some volume related hypertension. Urine albumin was 3+, reactive urine sediment, creat was 1.8. We evaluated this patient. This patient had a progressive decline in renal function, became almost oligoanuric, requiring dialysis. A renal biopsy was done which showed crescentic glomerulonephritis. He was ANCA positive, and this is a case of ANCA positive vasculitis in a male diabetic. So once again, this is not a case of diabetic nephropathy. In this particular patient, we did a biopsy, we pulsed with methylprednisolone and also was put on cyclophosphamide, and he went home with a near normal renal function. Now let us look at this case, case 4, 56-year-old female, diabetic for 22 years. She had edema, hypertension, urine albumin was 4+, no RBCs, creat was 4.5 and hemoglobin of 8.8. Any third-year medical student will tell us that this is nothing but a case of classic diabetic nephropathy. Long duration of diabetes, patient has edema, hypertension, anemia, renal dysfunction, urine albumin is 4 plus, and there is no active urine sediment. So this is a case of classic diabetic nephropathy. So what are the points on which we would make a diagnosis of diabetic nephropathy? First is duration. A patient, particularly in type 1 diabetes, the patient comes like the first case that we presented, a young female who presented at the de novo presentation was oliguria, dehydration, and firstly diagnosed very high blood sugar, 460 or so, and renal dysfunction. It's unlikely that the patient will have diabetic nephropathy. So you have to have some duration. Conventionally in class 1 it is a type 1 diabetic state, it is about 15-20 years, but class 2 you may have at the very onset, but still there has to be some duration of diabetes. Proteinuria. By conventional teaching, diabetic nephropathy to a nephrologist is synonymous with macroscopic proteinuria. In early stage you may have microscopic proteinuria, but in a full-blown case of diabetic nephropathy you do get macroscopic proteinuria. Bland urine sediment, if you find RBCs, RBC casts or dysmorphic RBCs, it speaks more in favor of non-diabetic kidney disease. Retinopathy, by and large, vast majority of patients of classic diabetic nephropathy have retinopathy. Hypertension, a patient of diabetic nephropathy of some duration having proteinuria, renal dysfunction, hardly you will find normal blood pressure. If you find a patient whose blood pressure is normal, who is dry, think 10 times before making a diagnosis of diabetic nephropathy. Proteinuria, I would like to spend a minute or so on proteinuria, because sometimes it may be dipstick positive proteinuria, there is a classic diabetic kidney disease, but you may also have dipstick negative proteinuria when you get microproteinuria. One should remember this microproteinuria, in only one snapshot microalbuminuria is not diagnostic. You have to have at least 2 cases of microalbuminuria of 3 samples over a period of 6 months, and this patient should not have urinary tract infection, a non-ketotic urine, and should not be having uncontrolled blood pressure. And now this microalbuminuria has been redefined as more than normal proteinuria. You may have massive proteinuria, as for example 10, 12, 15 grams of proteinuria. When you do have, question once again the diagnosis of diabetic nephropathy, because diabetic nephropathy per se, the classic diabetic kidney disease, usually is not associated with massive proteinuria. If you have massive proteinuria, you may have other possibilities, as for example amyloid kidney disease, where you may get very high amount of protein excretion in the urine. And once again, presence of hematuria brings forth a question about the diagnosis of diabetic nephropathy. I think this issue will be discussing in another slide shortly. So conventionally speaking, this diabetic kidney disease, which was previously called as diabetic nephropathy, now we nephrologists prefer to say diabetic kidney disease, passes through 3 stages. The first stage is the silent stage. This is the stage where the GFR is usually more than the normal GFR, maybe 120 or so. Proteinuria is normal, usually less than 30 milligram. Renal function is normal and blood pressure is normal. Unfortunately, in this silent stage, hardly we can make a diagnosis. So sometimes we miss the diagnosis until unless we check the GFR. The second stage is the incipient stage. This is the stage where one should make a diagnosis of diabetic nephropathy. Here the GFR tends to come down to almost normal range, around 100 or so. Proteinuria rises from say less than 30 to between 30 and 300. This is called incipient nephropathy, and you have this microproteinuria. Renal function is still normal, it is less than 1. But there are some subtle other changes which we also sometimes miss out. As for example, normally there is a diurnal variation of blood pressure in any healthy individual. That is, at early morning or late night there is a drop in blood pressure that is called nocturnal dip. In many patients in incipient stage, this nocturnal dip is lost. They are non-dippers, and as the renal dysfunction progresses, there is not only a loss of dipping at night, but there may be a rise in blood pressure at night. These are called reverse dippers or risers. This is a very interesting subtle change. If we can make a diagnosis, then subsequent stages of diabetic nephropathy can be foretold. Similarly, you may have signs of autonomic neuropathy, but by and large, primarily we go by proteinuria, which is between 30 and 300 milligram or 20 to 200 microgram per minute, and that is the definition of more than normal proteinuria, or previously it was called microproteinuria. In overt nephropathy, you get dipstick positive proteinuria. This is the stage where you get a fall in GFR, the creatinine starts to rise, that means renal dysfunction sets in, blood pressure starts to rise, and the proteinuria may be 1 gram, 2 gram, 3 gram, but hardly it reaches more than 8 or 10 gram. But as I have already said, if it is massive proteinuria, once again you should question the diagnosis of diabetic nephropathy, and sometimes a renal biopsy is indicated. So, with these statements, let us try to find out one of the standard definitions of diabetic nephropathy, which was proposed by Remuzi as early as 2002. He suggested that diabetic kidney disease, as I said, now we say diabetic kidney disease in stage of diabetic nephropathy, is a clinical syndrome characterized by overt proteinuria, that is 300 milligram per day, and declining renal function, often preceded by progressively increasing urinary albumin excretion, that is 30 to 300 milligram per day, usually described as incipient diabetic nephropathy I have just described. So, the question is, what are the parameters which can distinguish between non-diabetic kidney disease in a diabetic patient from classic diabetic nephropathy? A recently published meta-analysis once again tells us or gives us some clue. They say that dysmorphic RBCs in urine and RBC casts, but not microhematuria or microscopic hematuria only, which is predictive of non-diabetic kidney disease. Secondly, a few years ago we used to say retinopathy is a hallmark of diabetic kidney disease, but now it has been shown that retinopathy may be absent in as high as about 24% of classic diabetic kidney disease, but present in 17.6% of those without diabetic kidney disease. That means the message is retinopathy may or may not be a diagnostic marker or a clue to the diagnosis of diabetic kidney disease. What about proteinuria and GFR loss? From this point on, we will try to find out a recently generated idea or recently generated interest in a separate group of diabetic kidney diseases. I am citing 4 studies. These are published in the last 6 or 7 years. If you scan these studies, you will find the number of patients are 4,000 to nearly 16,000. GFR in these patients, this group of patients, in about more than 20%, 19, 22 and 23% cases, GFR was less than 60. But you will find albuminuria is to the extent of macroproteinuria is only 13%, 13% and 13%. In other words, as we have described a few minutes ago, that in the classic description of diabetic nephropathy, you get florid proteinuria and then only you get loss of GFR. Here you will find GFR has already fallen below 60, but still in some of the patients, in a sizable number of patients, you do not get proteinuria. So, there is a group, a new group of patients which have been identified, which are normoproteinuric or only microproteinuric diabetic kidney disease, who may have a GFR which is less than 60. That means renal dysfunction in presence of near normal proteinuria. If we go into a cohort study, this is a longitudinal study I am citing. This was published in Diabetes Care in 2012. 600 patients with type 2 diabetes having normo or microalbuminuria, and these are followed up for 4 years. GFR was measured by iohexol clearance every 6 months, and you know iohexol clearance is the gold standard. Here median GFR decline was 3.37 ml per minute per 1.73 meter square. Interestingly, you observe that in normoalbuminuric patients, this GFR decline was even more than the median GFR, and in microalbuminuric patients it was less than the median. That means those who did not have any proteinuria had a further had a more increased loss of GFR in comparison to those who had microalbuminuria. So there is no direct linear relationship between proteinuria and loss of GFR. Then what could be the possible risk factors? The first risk factor is female sex. Women with type 2 diabetes are at a greater risk than men for accelerated GFR decline in the absence of proteinuria. And in the Swedish National Diabetes Registry cohort, the association between female sex and reduced GFR was quite robust, with an odds ratio of 4.03 compared with men. If we go into the animal experiments, it is said that streptozotocin induced diabetes is a model of type 1 diabetes. And here it was found that 17-beta estradiol, that is the female hormone, has been shown to have a protective effect on diabetic renal disease. But what happens in obese Zucker rats? Obese Zucker rats are a model of type 2 diabetes or obesity or insulin resistance, and here renal failure occurred earlier in female animals. That means in type 2 diabetes models in animals also, it has been found that the females are less protected, rather they are more prone to develop renal dysfunction in this non-proteinuric class of diabetic kidney disease. The other entity is metabolic syndrome. The components of metabolic syndrome associated with non-proteinuric type, this is the type that I am describing, non-proteinuric GFR decline include severe obesity, high systolic blood pressure and pulse pressure, high triglyceride concentration and insulin resistance. And the more interesting part is females who have metabolic syndrome are more prone to develop this typical variety of non-proteinuric or so-called normoalbuminuric GFR decline. So this new variant is more prevalent in metabolic syndrome patients who are females. As we know, metabolic syndrome and also diabetic kidney disease is also associated with insulin resistance. Insulin resistance has been implicated in the pathogenesis of renal damage in diabetic kidney disease. One possible explanation is metabolic mediated disruption of capillary vasoregulation leading to vasodilatation of both afferent and efferent arterioles. We nephrologists know that as there is more and more blood inside the glomerulus, we call it intraglomerular hypertension, and intraglomerular hypertension is associated with faster decline in renal failure. Progression of chronic kidney disease is faster in those who have intraglomerular hypertension. The other mechanisms may be upregulation of SGLT2 leading to proximal tubular salt reabsorption and secondary worsening of hyperfiltration through tubuloglomerular feedback, low circulating level of adiponectin and downregulation of nephrin expression, and high circulating leptin, a pro-inflammatory cytokine. There was a recent publication called Look Ahead trial where an open label randomized study on more than 5,000 obese type 2 diabetic patients show that mean body weight reduction of 4 kg was associated with a reduced incidence of very high risk chronic kidney disease by 31% at 8-year follow-up. So this is the other side. So not only that we find that metabolic syndrome and obesity is associated with a faster decline, but if you look at the picture from the other direction, if there is significant weight loss, that is associated with a reduced incidence of high risk of CKD, and there is an improvement in terms of renal failure progression. And if we go by bariatric surgery, the same thing. If by bariatric surgery, if you can achieve a loss of 20 kg of body weight, in addition to achieving the primary endpoint hemoglobin A1C of less than 6%, there was a 38% reduction in albuminuria. So once again, if you go by bariatric surgery and you can achieve the status of the body weight is normalized, then once again this insulin resistance improves and there is a progressive improvement in renal failure progression. This is another way to look at this thing. There is a group amongst the obese individuals which are called metabolically healthy obesity. It is not that all obese patients are bad. About 10 to 30% of obese individuals are not at increased risk of metabolic diseases. They have low insulin resistance, low carotid intima media thickness, lower prevalence of visceral obesity, which is characterized by non-alcoholic fatty liver disease, and they also demonstrate a low level of hepatokine 15A. Interestingly, these patients have a low susceptibility to develop diabetic kidney disease. So, amongst obese patients also, if insulin resistance is non-existent or less existent, less prevalent, then you find these patients are relatively protected against diabetic kidney disease. What are the possible risk factors? The first risk factor, let us look at angiopathy, microangiopathy versus macroangiopathy. We all know that microangiopathy is synonymous with diabetic kidney disease, and one of the features of microangiopathy is retinopathy. So let us look at the issue of retinopathy. In the RIA study, in more than 15,000 patients, it was found 1673 had GFR less than 60, and these patients had normoalbuminuria. Interestingly, these patients had advanced retinopathy. Retinopathy is a marker of microangiopathy. So, the reduced prevalence of retinopathy in DKD patients having low GFR and normoalbuminuria might exclude microangiopathy as a cause of non-proteinuric decline of GFR in these patients. So, if you look at this study, you will find only 10% of patients had GFR less than 60 and normoalbuminuria, and these 10% had retinopathy. So, there is a discordance between retinopathy and renal dysfunction. A sizable portion does not have retinopathy, but still they have GFR less than 60. So, this proves that retinopathy, in other words microangiopathy, may not be the basic underlying pathologic mechanisms in this subset of normoalbuminuric diabetic kidney disease. So, the other possible explanation could be not microangiopathy but macroangiopathy. So, it is proposed that in this normoalbuminuric loss of GFR in this DKD population is possibly associated with macroangiopathy. The other issue is glomerular hyperfiltration. It is said that, as we know, and in a few slides ago I have shown that in the first stage, in early diabetic nephropathy, we find that the GFR tends to rise maybe 120 or 130, 40. There also it has been found that those subset of patients who have a relatively higher induced GFR, that is GFR is more than 120, they are more prone to develop this non-proteinuric form of diabetic kidney disease. And also those patients who resist the drop in GFR. That means some patients will have a faster decline in this high GFR in course of time, but there is a subset of patients who will not show early decline in GFR, and these are the patients who are likely to develop this normoproteinuric variety of diabetic kidney disease. Next question is, what about the element of RAS blockers and GFR decline? I will cite at least two group of studies. In the first study, in the Benedict B and Demand combined study, which showed that in type 2 patients with normoalbuminuria or microalbuminuria, that means these have relatively lesser amount of proteinuria, treatment with ACE inhibitors had identical effect on GFR decline as in those who are not. That means in these patients, ACE inhibitors did not have any significant effect on GFR decline. Similarly, in 285 type 1 diabetics, these were normotensive and normoalbuminuric, the decrease in GFR and the change in mesangial fraction volume over time were identical in three groups treated with enalapril, losartan and placebo. That means in these group of patients where proteinuria is less, ACEs ARBs did not have appreciable effect on GFR decline in the non-proteinuric stages of diabetic kidney disease. What about the significance of albuminuria in these patients? We know that proteinuria is a marker of cardiovascular disease, a risk factor for cardiovascular events starting from as low as 1 microgram per ml. But what about renal failure? What about GFR decline? In the Swedish National Diabetes Register, urine albumin excretion started to increase in 16% of incident cases only after GFR declined below 60 ml per minute. That means here GFR declined before there was a rise in proteinuria. Once again, there was a discordance between fall of GFR and rise in protein. And albuminuria, now we know, is a non-specific marker. It can be associated with insulin resistance, metabolic syndrome, dyslipidemia, endothelial dysfunction, and subclinical inflammation. Now that we have discussed about the functional aspects, can we look into the renal histology inside the kidney? What is happening? About 20 years ago, Fioretto published a pioneering experiment where it has shown that in about 30% of patients with microalbuminuria, renal histology may show a spectrum of lesions starting from minimal histologic changes, that means almost normal looking glomeruli, to classic diabetic glomerulopathy, and in between you may have a spectrum of diseases. That means the stage of microalbuminuria is not a homogeneous one. It can show various types of renal histologic lesions. And recently there is a very interesting study published by Buddhiraja and his group. They tried to address this issue in a novel way. Many diabetic patients, they undergo nephrectomy because of RCC, renal cell cancer. So these patients have kidneys. These patients are diabetic patients, but normally we cannot take out the kidneys. Here they got the whole chunk of kidneys because these patients were suffering from renal cell carcinoma. And they did biopsy of those kidneys, those patients who are falling under this category. That means normoalbuminuric patients or near normal proteinuria, they do not have overt proteinuria. And what is their observation? Very interesting. Classic KW nodules are observed in 8 out of 10 patients, 80% patients. So these patients did not have significant proteinuria. They had diabetes. So by definition, we do not classify them as a case of classic diabetic nephropathy. Renal biopsy done, and biopsy shows in 8 out of 10 patients they have classic diabetic kidney disease lesions. So there is once again histologically also there is a significant discordance between histologic appearance and clinical picture. So what could be the explanation? The explanation by and large is possibly it is tubulointerstitial damage, which is the typical feature of this non-proteinuric phenotype of kidney disease in type 2 diabetes. So let us address this issue at a relatively greater depth. Before going into the recent published work, I like to highlight on the classification of diabetic nephropathy by Renal Pathologic Society, which was published in JSN 2010. Now we know that there is a glomerular classification, class 1 to class 4 lesions, interstitial fibrosis and tubular atrophy scoring, there is IFTA scoring 0 to 3. Then you find interstitial inflammation scoring, arteriolar hyalinosis and arteriosclerosis, of which the most important are the glomerular lesions and the IFTA scoring. Now let us see what is happening. This was published in 2015 in Nephrology, Dialysis, Transplantation, recent publication. They tried to correlate between renal histologic changes and outcome in diabetic nephropathy. Glomerular lesion, 5-year renal survival. Class 1, that means minimal lesion, 100% renal survival, no question. Class 4, advanced lesion, 15.3% 5-year renal survival, no question. Once again, these show that as you ascend in the ladder of glomerular lesions, the 5-year renal survival comes down. There is no controversy. What about IFTA? Interstitial inflammation scoring is not important, but what about the IFTA scoring? Interstitial lesions, once again, as you ascend in the lesions, you will find more and more patients have interstitial lesions, then the GFR decline is also faster. Here also there is no question. You get more tubular interstitial disease, you get more advanced chronic kidney disease with low GFR. Now, the most interesting part, you have both. You have both renal histological changes in terms of glomerular lesions and interstitial lesions. What happens? Those who have mild glomerulopathy, that means class 2A, but having severe IFTA scores, had a low eGFR. And to the contrary, those who have severe glomerulopathy but mild IFTA, the baseline MAP and the proteinuria were low. So what is the significance? The significance is, if we take two groups, one group have severe glomerular lesions and less severe tubular lesions, they are relatively better protected. Whereas those patients who have relatively less of glomerular lesions but more of tubular lesions, they are not protected. So it is not glomerular pathology, rather it is tubular pathology which ultimately dictates which of the patients will have a faster decline of GFR. Actually, recently it has been found, when we were students, we were taught that proteinuria is a function of glomerulopathy. Now it is said it is more a significant marker of tubulopathy. What happens? Suppose the glomeruli are damaged and the pore is widened, there is more filtration of protein. If tubule is functioning properly, then there will be avid tubular reabsorption of protein. So if glomeruli are involved and tubules are not involved, then though there will be significant proteinuria at the glomerular level, that protein will be reabsorbed from the tubules by avid tubular reabsorption of protein. If tubules are also damaged, then that protein will not be absorbed. So when you get only glomerular injury but preserved tubular function, you may or may not get, rather you may not get, more likely that you will not get significant proteinuria. But if tubules are damaged together with glomeruli, then the protein that is being filtered in excess from the glomeruli will not be reabsorbed by protein, and then you will get more proteinuria. So proteinuria is a function of glomerular injury plus tubular injury rather than glomerular injury alone. So what are the therapeutic implications? Because we are nephrologists, we are not there to explain the pathogenetic mechanisms or the renal histology. We are there to see how we can treat these patients. RCTs attempting to examine the efficacy of renoprotective interventions almost invariably exclude patients without albuminuria. It's very unfortunate because we are being taught that albuminuria is synonymous with diabetic nephropathy. So all patients who did not have albuminuria were selectively excluded. By doing so, about 50% of diabetic population having some degree of renal dysfunction and who are at risk of disease progression are kept away from the study protocol. So the risk benefit profile using RAS blockers in this patient population is unknown because we don't know these patients who do not have significant proteinuria, how does RAS blockers work? A rigid model of thinking and a standard therapy in all diabetic kidney patients, especially in the non-proteinuric variety, is to be avoided. And in a recent publication in Lancet Diabetes Endocrinology in 2015, the authors recommend that the best approach in this patient population, that means the normoproteinuric patients having low GFR, the best approach should be an individually tailored, response-driven intervention titrated to metabolic and blood pressure control with or without RAS blockers. I repeat, with or without RAS blockers, and side by side close monitoring of possible side effect, especially hyperkalemia and worsening of kidney function. We nephrologists all know the real problem of RAS blockers in advanced diabetic kidney disease are A. hyperkalemia, B. worsening of kidney function. So they propose that a blanket treatment of all diabetic kidney patients with RAS blockers should be avoided. So the treatment should be tailor-made depending on the specific pathologic entity. So how should we conclude? In conclusion, I would like to say that renal dysfunction in absence of significant proteinuria may be observed in as high as 50% of type 2 diabetic patients. It's a new entity we were not aware of, but now slowly this new entity unfolds itself. Declining GFR may be present before or in absence of proteinuria. Progressive loss of GFR and sequential increment of albuminuria may be two different pathways in type 2 diabetics having nephropathy. This second phenotype, that is without proteinuria, is more prevalent in women and in the metabolic syndrome. Macrovascular rather than microvascular injury and tubulointerstitial damage may be two different pathogenic mechanisms underlying this subset of patients. Benefit by treating this group of patients with RAS blockers still remains uncertain. Individually tailored and response-driven treatment is ideal in this particular group of patients. Thank you very much.